co-leader of the COVID Force that is one of the sponsors of this, as well as RADx and the Acme POCT. So we're delighted to have everyone here. We have a really great, interesting seminar planned today, and I'm going to turn it over to Dr. Claudia Morris, who is our Center for Clinical and Translational Research co-director, to introduce our wonderful speaker. Claudia, take it away.
All right. Good morning, everyone. Thank you, Stacy. And I'm delighted to have the opportunity to introduce Dr. Mark Griffiths. He's an associate professor of pediatric emergency medicine at Emory University and the medical director of Children's Healthcare of Atlanta, the Hughes Spalding Emergency Department. He studied biomedical engineering at Yale University, after which he obtained his medical degree from the University of Cincinnati. Dr. Griffiths then completed his residency at pediatrics at Cincinnati Children's Hospital Medical Center and his fellowship right here in the Pediatric Emergency Department at Emory University and Children's Healthcare of Atlanta. He was actually one of our stellar PEM fellows when I first joined Emory and Children's. And a little personal tidbit about Dr. Griffiths, he has the most contagious laugh. Just hearing it makes my day. Clinically, he's the sort of team player in the emergency department that you're always happy to share a shift with. And his academic work is focused on emergency department throughput, improvement of access to care of pediatric patients for infectious diseases, and biomedical device design. Dr. Griffiths is a member of the Rapid Acceleration of Diagnostics, or RADx, Test Verification Corps, tasked with assisting the validation of COVID-19 point-of-care testing platforms, which has been so important during this crazy pandemic. So I'm really looking forward to his presentation on an oasis in the medical desert, bringing COVID-19 testing to under-resourced communities while also helping to develop point-of-care testing strategies. Take it away, Mark.
Thank you so much for that introduction, Claudia. Good morning, everyone. My name is Mark Griffiths. I'm going to share my screen here, and hopefully you all can see it. Can you see it okay?
Yes.
All right, perfect. And then can you hear me okay as well?
Yes.
Yeah, perfect. Great. So today I'd like to take you on a little journey of our test validation group as we combined our primary research efforts with a public health initiative. Specifically, we help to develop point of care test strategies while helping our city mitigate the spread of COVID-19. I have no financial disclosures to report to the dismay of my family. And the goal of this talk is very simple. In addition to taking y'all on this RADx journey over the next 45 minutes or so, my hope is that we'll also provide a template for an academic and community partnership for future projects to handle problems here in Atlanta and also around the country. And so I'd like to start with my last slide, the summary slide, because I'm very fond of this adage, beginning with the end in mind. And it's intended that by the end of this presentation, the principles on this, my last slide, will make absolute sense, and that we all will hopefully consider these principles in our future clinical research projects. One, consider hybridizing our initiatives, finding a dual purpose for all of our projects. Keep asking questions, especially of the people we're trying to serve. And third, leverage our academic affiliations with community partners, finding a friend and finding some new ones so that we have the most impact as possible. I think in order to get a full appreciation of the work that's going to be presented, it's important for us to remember what life was like before COVID and at the very beginning of the pandemic. These were times of disbelief for many of us in the United States, something that we couldn't have thought of 20 months later that would actually happen to us. And if someone were to tell me in the first week of March what the last normal life week was going to be like, I would have sworn they would have been drinking too much rum punch. And that's because the first week of March, this was my scene when I woke up. Here I am on the beaches of Anguilla, enjoying a celebration with our friends that we had planned for over a year to celebrate her 40th birthday. A group of 10 of us traveled down there. And that morning, my last morning there, I enjoyed a delicious Caribbean breakfast, grabbed my complimentary coconut water from a freshly cut coconut, got ready to head out for an excursion around the island, last hurrah, if you will. And I didn't have any concern about email and piling up. I didn't have any knowledge of what Zoom was. I could just fully detach and relax, which is in stark contrast to just a month later when this would become our reality. COVID-19 had started to spread around the world. And this viral infection that we heard of in other parts of the world had started to arrive on our shores, officially being declared a pandemic in March 11th, just 3 days after I got back from my wonderful vacation. And it took over the headlines. From my native New York to the Philippines, all of the headlines were talking about this COVID disease that was spreading, how testing was a challenge for everyone, and how by April and May, we were talking about how March had been a lost month, where if we had gotten a handle on testing, we could have handled the first wave better and maybe even subsequent waves that were to come, all because we didn't have the testing and tracing in place. And if you looked at all the literature online, people were talking about how this was going to be like the flu pandemic of 1918. Here we have snapshots from the CDC Pandemics Basics webpage, and they're talking about how in 1918, this pandemic came to us in several waves that would affect millions of people, that would affect countries of all sizes, of all scales of economies, and all types of healthcare infrastructures. Little did we know that history was going to give us a preview to what we had in store, where testing was going to be an essential component of overcoming this pandemic. And then what we also didn't know was that a surge was coming unlike what they saw in 1918 with the advent of all the variants and the lack of testing. What we also didn't realize was that this testing was going to affect all of us. Similar to 1918, it affected people all across the country, from Washington State to New York. And we all struggled with securing testing components, with identifying sources of infection, all in efforts to mitigate the spread of this virus. And so testing became the highest priority until a vaccine could be developed and distributed to a critical mass of the population. And as we found routes to tackle these challenges of ramping up testing kits and increasing folks' access to tests, we started to see a separation of who would benefit versus those who would be left behind. All over the country, we saw examples of ways forward, particularly in these drive-through testing sites. But as I look at this picture, an example that you could take from any city's evening night news, I can't help but think of a few things, because in line here were folks like me who had means to take off time from work, maybe work remotely, and then were able to conveniently drive to a testing location while being able to afford the gasoline required to stay in line for hours, then comfortably drive home, and then reliably go online and check their results. And what this means is that the inverse is probably true. For those with limited means who might not have a personal vehicle, and even if they did, might not have a testing site considerably close to their home, and if they did, might not have a reliable way to obtain those results. These folks, our neighbors, our fellow ATLians, were essentially like nomads in the desert. And so these folks who might be looking for any help in mitigating the spread of COVID in their neighborhoods and might be doing what they could to protect themselves and their families were essentially living in what's described in the literature as a healthcare or medical desert. So I'd like to go into the definition of that a little bit more. A healthcare desert or a medical desert traditionally in the literature describes rural environments, but the core of it is the same. It's a geographical area with limited access to various components of the healthcare system. So that could be trauma care, maternal health care, primary or pharmaceutical services, or laboratory services. And while for the majority of the literature, it describes rural environments where they describe it as areas that are 60 miles away from an acute care facility, the definition has been revised to account for urban environments where the threshold is lowered to 5 miles. And this is not an issue isolated to Atlanta. It's not an issue just for northern Georgia, because there are medical deserts all over America. So a local problem could be easily generalizable. But since we're talking about Atlanta, let's dive a little bit into the geography, just because I know we have some folks on the line who might not be familiar with our great city. So how does one get around Atlanta? Well, we have a 285 loop here, I-285, that sets up a spoken wheel kind of pattern. So you've got the 285 loop, and to the northern suburbs, you've got Cobb and Gwinnett. To the west and to the east, you've got Douglas and DeKalb counties. And to the south, you've got Clayton. And of course, you've got the mighty Fulton County covering up the medial aspect of the metro area. And as a proxy to that acute care terminology that's in the healthcare desert definition, one could simply search for urgent care centers in Atlanta and would get this map to pop up. And what we see is a good number of urgent care facilities are located in the north, to the east, and even a smattering to the south and the deep southwest. However, if you look closely in town, there are large donut holes to the west and southwest areas of the city. And so while there are smaller pockets in the north and the southeast, this area in the southwest really, really catches your eye. If you dig a little bit deeper and overlay that proximity to healthcare facilities with some economic information, such as median household income, we see a theme emerge. And in that theme, you see in that donut hole an area of the city where the heat map just starts to come off the page. In this area of the city, we have a concentration of folks who average less than 40,000 a year. There are notably difficulties in getting access to testing facilities and healthcare facilities. And this range could be as small as 6 miles to as great as 28 miles, depending on where you start out in the donut hole and which direction you set forth. And this is a phenomenon that's not just relegated to America. This is an international problem, one that the International Monetary Fund has made several mention of, in that in higher income countries, this tends to be a dominant theme. And we notice that in order for us to get through this pandemic together, one very important step is scaling up testing. And so even though it hits the poor harder, we have a route forward if we can just activate those resources. And so what could the local scientific community do to help, was a thought that came to many involved in a project that I'm going to speak about a little bit more detail shortly. And we knew that in this project, there was access to ramping up COVID testing for the general population, and that would be a long-term effect. In the short term, because many of these researchers are hospital-based, healthcare systems-based, there was an opportunity to bring some of these hospital-based testing capabilities into the community, focusing on areas that had limited access to no-cost testing. Because we know that private citizens sometimes take on this mantle as well, it's very admirable that they would do so, but the reality is it's not guaranteed to have equitable outcomes. In this example right here, a private citizen and actor, Sean Penn, set up a testing facility in Orange County, setting up in both a middle-class neighborhood, Westminster, where the average income is $60,000, as well as Malibu, a fairly elite area where the average income is $150,000. And I can't help but see that while this effort was very valiant, there's something that just pops off the page to me, and it's the cost of this swab, where even if you're middle class, you would have some pause at spending $125 just for a test. And the reality is that this is actually not an exorbitant amount compared to what was being offered in some communities, where we've heard the test average up to as high as $500 per swab, which of course would be cost prohibitive to almost anyone. So the question then became, how could a group of scientists help alleviate this challenge for our neighborhood? And in comes, on stage left, the RADx project, or the Rapid Acceleration of Diagnostics. For those that aren't familiar with it, it's an NIH-funded program for scientists and organizations designed to speed the development and the validation of innovative point-of-care testing. It also seeks to improve clinical laboratory tests that already exist so they can more aptly detect the virus. And all in an effort to get as many point-of-care tests available to the general American population. And so through a series of Shark Tank-like stages, these promising devices would be curated and approved and then brought to the public en masse. And so our RADx team had an opportunity to become an essential part of this, not only for Atlanta, but for the rest of the country. And then who is part of the RADx team? So leadership starts with leaders from the NIH, as well as local leaders from Emory, Georgia Tech, and Children's Healthcare of Atlanta. Already existing were teams of collaborators in this Atlanta Center for Microsystems Engineering Point of Care Technologies group from Georgia Tech, Emory, Children's, who had different buckets that they managed. And in combination with their efforts, were able to enroll some colleagues to then enhance the efforts of this team. So with Georgia Tech engineers lending their expertise on device design and human factors, with Emory and Children's faculty lending their expertise in virology, clinical and translational, population testing and sample collection, as well as clinical lab assessments. And then Emory and Georgia Tech faculty also lending their expertise in navigating the very torturous regulatory environment so that we could get these devices to market as efficiently as possible. So how does this work? Company X designs a COVID test that they feel would be easily done over the counter or easily done by somebody that can purchase it from over the counter. And they submit that testing kit to the RADx team for evaluation. The team then does their evaluation in their set domains and then would give feedback not only to the NIH, but also to the company so that they could improve their product. This feedback would come in the form of biosafety analysis, device usability, instructions for use recommendations, operational performance, sensitivity and specificity data, as well as recommendations on how to optimize their EUA submission. And so we understood that RADx had the ability to fill a testing need in the Atlanta community. In essence, we had an opportunity to serve. We also understood that our community had a lot of trust in our healthcare institutions and that they felt safe with us. And we understood that if we crafted this correctly, the information we learned could inform other communities around the nation about which testing platforms could be implemented, because certainly in Georgia, we had a fertile environment from which to test and sample. We also had the opportunity to bring the tests to areas of our community that had been disproportionately affected in terms of access to testing. So in essence, we had an opportunity to offer a sense of relief to these communities. And so essentially, we had an opportunity to help our patients at multiple levels be this oasis in a desert. And it's interesting that oasis is what pops up in our heads, because if you look at the definition of oasis, some of those themes are in the very definition if you go from text to text. One text describes an oasis as a fertile spot in a desert where water is found. Another describes it as something that serves as a refuge or a pleasant change from what is usually annoying and difficult. A third text describes it as a place of peace, safety, or happiness in the midst of trouble or difficulty. And the fourth dictionary I could find describes it as any place offering welcome relief from difficulty or dullness. And certainly that's what we were seeking to do for our Atlanta community. So we understood the situation. We knew we had resources to help. Now we just had to figure out where to focus our efforts. And so what was on our Oasis checklist? Well, we knew we wanted to focus our efforts because we had limited, not funds, but resources in general. But we also wanted to have far-reaching impact. We wanted to set up in underserved areas and leverage our NIH funding, not only for research, but for public health impact. And so these 3 points became our North Star, and we wanted to focus it on a population that we felt was vulnerable and often overlooked. And what population fits that bill more so than our children? Because from the very beginning, we knew that access to testing in various communities was challenging, but especially for our children, where if in the early days you tried to take your child to a testing facility, they might not have felt comfortable testing a child. And if they did, they struggled with getting timely results, because remember, in the early days, it would take up to 10 days to get those results. And so if this happened in school, if this happened in a daycare setting, it could be pretty detrimental. And so we also knew that multiple school districts in the Atlanta area were citing these testing challenges as hindrances for them getting back to in-person instruction. Because remember, they abruptly canceled in-person instruction in the latter part of spring 2020. And so with limited available opportunities and resources, not only for their students, but their staff and faculty, we thought this was a great place to go. And so we reached out to several school districts in the Atlanta metro area that were seeking to resume in-person instruction after the December holiday break. And when we look back at who we took care of, mostly it was a collection of a handful of districts. And so we reached out to them, presented the ideas of what we thought we could reasonably offer them. And I have to give a shout out to my friends at CHOP who advised me on another project we were working on at the same time. And they always reminded me to go where the energy is. And certainly the energy was palpable from the Atlanta Public School leadership. In that first meeting, or in preparation for that first meeting, when we looked at what we had on the table there, the APS system met all the criteria that we were looking for. They were the largest school district in the metro Atlanta area with greater than 50,000 students, another 5,000 faculty and staff, not to mention their families. So that checked off the box of being focused but having far-reaching impact. A significant portion of their students lived in households where that median income was less than 30,000. So that definitely checked off the underserved area North Star. And then lastly, we knew from our patient data at the hospital that a significant percentage of our APS students lived in medical desert. So definitely this could have a public health impact. And how did it go? It went great. We laid out for the APS leadership what resources we had, threw out some ideas that we thought we could quickly implement. as well as a testing strategy that could be implemented by spring of 2021 when they were scheduled to come back in person. We got input from Emory and children's ID physicians, primary care pediatricians, and pediatric emergency medicine physicians. And really, all of our ideas were really well received. They appreciated the clinical updates. They thought that this was a feasible plan and that they could feasibly get their kids back in person, which they knew they had to do for their own kids' well-being. And this was leadership from the superintendent of schools to the director for healthcare related services, their chief equity officer, and their assistant superintendent, all on the call. And after that first meeting, we were excited. I don't think we've had a collection of folks excited in Atlanta since Dominique Wilkins won the slam dunk championship back in the 80s. We were slated for a 1-hour meeting with Dr. Herring and her crew, and it lasted nearly 2 hours before we looked up at the screen and saw how long we'd been on the call. And Dr. Herring actually let us know that they had actually been approached by several entities looking to offer testing, but they really felt connected to the idea that we had presented and felt that it resonated with them the most because they appreciated the alignment with federal and local resources. They thought it would overcome some of the hurdles that they've been hearing from their families when it comes to credibility from these healthcare resources. And then the prospect of being able to contribute to something larger than oneself. So yes, you could find out your own COVID status, but the fact that we could contribute in that same effort to helping people in the future and outside of Atlanta, they felt would really resonate with not only the students and the teachers, but their parents and the rest of the staff. So we made preparations for the second meeting because this was just a few days before Thanksgiving. And so we made preparations to meet up again in December after everybody got back from the holidays. And then we pretty much knew that we were going to try to finalize a testing strategy, identify necessary resources, and then target a start date. And anybody that knows me knows that I like to think in PowerPoint. And so we went ahead and put together a flow plan of what we thought would be feasible for the school district. And we gave them two options that we thought were reasonable. One was to train and accompany school-based nurses and get them involved in the whole testing process, as well as a second idea to utilize a resource that had been kind of put on the shelf for a little while when the pandemic first took off, which is our Ronald McDonald Care Mobile, which is an asthma mobile van that goes to around 13 different schools throughout the districts. And we had initiated some discussions with the Ronald McDonald Corporation to get a waiver for that. And then after that, to use a phrase from local Atlanta poet Jay Jenkins, and then what, we figured that we could then take some of the samples that we had, or all the samples that we would collect, absorb all the cost of all of that care, as well as study the device of the day. We would do all the reporting for the school district so that we would take that off of their plate. And then we figured with all of this, we could swab a few hundred students a week. And then if possible, and we had the resources to spare, maybe even squeeze in a few teachers. And all we thought we had to do was really figure out how we would inform the parents in the schools, identify which school nurses to train and work with, and then we would be off to the races. And so we were ready to celebrate. We were confident that we had a plan in place to help out our local school district. We were so confident in this plan that we went ahead and applied for that waiver from the Ronald McDonald Corporation so that everything could be good to go in a timely fashion. We actually did a trial run of using the asthma van at another community partnership event with the Mexican consulate where things were great and we were certain this was going to bring home another championship for the Atlanta area. And then right as we were about to lock up this championship, Dr. Johnson, who I refer to as the school-based clinic queen, one of our general pediatricians here at the Children's Healthcare of Atlanta, asked the APS leadership one simple question, and it was, what do you need? And as I looked over all my notes from the very first meeting in November, and I see all the questions that came up, this still resonates as the most important question that we've asked along the way. What do they need? And what they told us was that, especially from the superintendent, she loved the idea that we as the healthcare community were going to be bridging that gap of combating the misinformation and the mistrust that had been built up in the community. But what she really wanted was reliable testing availability. And she wasn't certain if moving around was going to give them that testing availability. The chief equity and social justice officer loved the fact that we were going to be absorbing many of the costs so that people wouldn't be dissuaded from seeking care. But what she wanted was a long-term partnership with a mechanism to continue after the RADx initiative was completed. And then the assistant superintendent loved our ability to give a short turnaround time, because by the time December had come around, the length of time had gone down from 10 or 14 days down to 5 to 7 days, but still that would be a challenge for the school district. So she wanted to be able to swab hundreds of kids, not on a weekly basis, but on a daily basis if needed, with that same kind of turnaround time. So we had to go back to the lab and think of some more solutions, because we weren't certain we would have all that we needed to overcome these hurdles. APS wanted to test up to 500 people a day. Our staff was built to test a max of 150 a day. How do we offer testing to even those that don't want to participate in research? Could we get approval to use our healthcare dollars, to use our research funding to pay for people who weren't participating in research? Could we get approved to work in this program beyond June of 2021 when it was slated to come to an end? And then what we really weren't factoring was that the school nurses were not entirely on board with being part of the testing. They had concerns about it. PPE was still a struggle at that time. And so we knew if we couldn't find answers to these three key problems, all the effort, even though it was well-intentioned, might fall apart. And so we looked to our school district. 2021 was the year of the hybrid. We saw that they pivoted really well from going from in-person to virtual abruptly in March and April of 2020. And then they pivoted and were starting to prepare to pivot from being strictly virtual to being a mix of in-person and virtual. And so we took our design cues from them as well. And we came to a conclusion that we needed a collaborator, a testing company that could help us offer this hybrid approach. Specifically, we needed a testing company with a testing model similar to our research teams. Whereas many sites around the city were offering rapid antigen testing, the superintendent was really adamant that she wanted RT-PCR, like what we were offering from the research side. And we wanted to make sure that regardless of which pathway our collaborators worked with us and that patients would come in and go down, we wanted them to have the same patient experience. We also wanted the company to have timeliness to their reporting, similar to what we could do. And we wanted to make sure that we were working with a company that we could work symbiotically with. And so specifically, we knew that as pediatric providers, we could spearhead that care for kids. We could bridge that gap in credibility and overcome fears of people being tested when they were fearful that microchips were being embedded in the testing kits. And then we knew that Children's, Emory, and Grady would give that boost of confidence to the community. We knew that we had the funds to bear some of the burden of the cost, as well as the infrastructure, not only getting it up, but keeping it up. And so funny enough, we found a collaborator named Viral Solutions, which is a private company here in Atlanta that had met all the criteria we were looking for. They had tested almost 200,000 folks by February 2021. They were able to get the results pretty quickly. And most importantly, they had made a commitment to us to continue the work beyond June 2021, just in case we weren't able to get an extension on our grant. And over the course of just about 45 minutes, we came up with a simple flow plan that works to this day. So a patient comes for testing, and we had an option for them regardless of which route they chose. Initially, they'd be presented by someone from the research team who would consent them for research enrollment. And if they agreed, the RADx team would do not only their standard COVID test, but a sample device collection so that we could run it on one of our sample study devices. If for any reason someone didn't want to participate in research, didn't feel comfortable, didn't have the time, they could go to get tested through our community partner. And our community partner, like I said, did an excellent job of meeting that need. And so when we look at our gumbo of our APS testing site, we all three knew we had to contribute something. So our APS team contributed the parking lot for the drive-through, some of the infrastructure needs they provided, including cones, tables, chairs, Wi-Fi access, electrical power, restrooms, and marketing on social media. Our RADx team, of course, would provide the research staff, and then for any swabs we did, reporting to the state lab. But then also things like tents, which are more expensive than people realize, signage and marketing. And then our community partner would offer their clinical staff a reporting tool, leverage their marketing team, and then also report their lab results to the state lab so that all that effort was taken off the plates of the school district. And so a few of us went on tours around APS. We visited 5 schools that they suggested for us to set up shop. And after all of this, we settled on Frederick Douglass High School. And if you were to look at this location and remember the map that I showed earlier of where that donut hole is, you'll see that Frederick Douglass lands squarely in the middle there. And so if I overlay the map from earlier with this map here, you see Frederick Douglass just sticks out like a sore thumb here, right there in the middle of that desert. In addition to that, the Frederick Douglass School was easily accessible. So if you're here in Atlanta, you know I-20 well, and it's literally feet from the I-20 off-ramp right there. If you're taking the local road, either via your car or via public transportation on the bus, there's a bus route literally right in front, a bus stop right in front of the school. If, however, you want to take the train, the MARTA, then the largest MARTA stop is right there, a few feet away from the school as well. So literally you can get there everywhere but by boat. So the location was settled. We agreed upon a launch date of February for clinical testing and March 4th for research enrollment, just so we can make sure we get a good flow of traffic and sense of how this was going to work. We staggered the start times of the different teams. We agreed upon a 9 to 5 Monday through Friday enrollment for all testing. Research team would take a sabbatical on Wednesdays to resupply and get instructions on the newest device that was going to come down the pike. And we agreed to do this through the end of the school year, possibly longer as a combined team if a no-cost extension was approved. And so as with COVID, everything moved quickly. So we began discussions in November of 2020 with APS. By January of 2021, we had settled on a testing strategy. By February, we started the process of setting up the testing site, getting the tents installed. And then we went live with our clinical testing on February 23rd, and then live with our research enrollment a couple weeks later. So we were definitely in Oasis mode. And our teams worked really well together. It truly became a symbiotic relationship. You know, our community partner knew from their other tents that marketing was key, so they volunteered their marketing staff to come up with a custom campaign. And here's a flyer that we sent out to the schools, posted on social media, used as many marketing tools as we could to get the message out there. And then we shared resources from things such as personal protective equipment, which at this point was a little bit challenging for our community partner to get gloves, and we were able to secure those for both of our teams. We were challenged with being able to provide snacks, but our community partner had endless snacks, and we were able to share that among our team. We shared things like propane tanks and electrical cords, and really worked as a functionally as one team. And it shows up in our comprehensive solution here, where we were very proud to have gotten this off the ground, especially in the time frame that we did. We were able to be a significant portion of the APS testing strategy to safely get the kids back in school. And not only were they able to get back in school, but they were able to stay in school without interruption, all while contributing significantly to the RADx mission. We were able to test multiple devices that were being validated, as well as biobank samples for later testing and use. Here's an example of the early days here. The tent has just opened up, and a mom and one of her children were symptomatic, I believe with a fever and a headache. They wanted to get tested. The research team approached them. They all wanted to get consented for testing. And it turns out there were 3 kids in the back who were also symptomatic, and mom didn't realize that they could be tested as well. So all 5 wanted to participate in the RADx project. Here we've got our research staff doing the consent process right here, while another member of the research staff is getting the study device prepared. And at the same time, we have 2 young men who just finished the overnight shift at their factory. They wanted to get tested, but they didn't want to participate in research. And that's okay, because we had an option for them as well. Here, while the research was going on the left side, on the right side, you see the 2 young men getting their clinical test done and off and out within 15 or 20 minutes. And so we truly had a plan for everyone. We thought that with this plan, we could reasonably test about 5,000 people during this spring semester of 2021. And at the same time, we knew that was an aggressive goal because we had multiple other sites going on as well. So RADx was not limited to this one site. It initially started with a team at Emory/Grady working out of North Lake Mall, a CHOA team working out of Children's Healthcare of Atlanta's urgent care site up at Satellite Boulevard. And then it expanded to other children's sites, to other Emory sites, including Grady Hospital, and then underserved communities such as Blairsville, Georgia, as well as the Consulado General de Mexico, the Mexican consulate, where you see Dr. Frediani here doing an interview while we are enrolling patients at the consulate needing testing. And then, as a nice step of good faith, our community partner extended their other sites to us. So we started enrolling patients at their other sites as well. So we had our hands wherever we could fit them in, wherever the hotspots were. But still, the APS site remained a very impactful location. How impactful? So in the very beginning, when enrollment was very high because the need for testing was very high, we comprised even 13% of the total RADx enrollment in March. As enrollment and desire for testing went down, you see the overall enrollment numbers going down, but at the same time, the RADx numbers staying pretty consistent at APS. And like I said, it was a very challenging time. We didn't realize that we were going to have such a precipitous decline, but we were very thankful to have this APS site in place because we were able to continue to enroll and contribute to the RADx project while impacting that community. And we were able to achieve these levels because here we see the enrollment being comprised of at least 13% of the RADx overall enrollment in March to as high as 41% of enrollment in June, primarily because we had an amazing team. I mean, this team was incredible. The way they presented it to the families, the way they engaged the families really lowered a lot of defenses, and it became a well-known staple in the community that we had Children's and Emory and Grady staff that were at this site that were being available to the community. And even our community partners, who they themselves might have been a little hesitant to test kids, would learn lessons from our pediatric team especially and incorporate that into their clinical testing. And our team did a great job. I mean, if you came to the site and didn't participate in research, it wasn't because of our team. It was because you were either in a rush or you had already contributed to the project. Our team was amazing. And our team even suffered through all 4 seasons. You know, we started in March where we almost had frostbite on all of our extremities, to June when we were drinking gallons of water and walking around with neck fans trying to endure the summer of Georgia. And then in between, we would joke that we would feel all 4 seasons in one day. So our team really persevered through some serious challenges and became superstars in the community. Public health wise, we really saw the impact there as well. You know, we set a goal of hitting 5,000 testees by the end of the spring semester, and we came very close to that. Once again, because of the testing demand going down, it became a challenge, but we hit almost 96% of our goal here at 4,800 tests being done at the APS site. And so, you know, July came, desire for testing was going down. People thought COVID was over, or they thought that it really wasn't as serious as it was in the past. And so we started to make plans to wind down. We thought it was best to reassign our research team to another location, but shut this down once summer school was out. And then something in the back said, well, let's just make sure that we can continue this from at least the first month of when in-person instruction comes back, just in case, not knowing that the Delta variant was on its way. And when Delta hit, oh Delta, we saw it. So here we felt it in the EDs, both the pediatric and adult facilities, which are, you know, very well-resourced facilities, and even we struggled to keep up with demand. But fortunately, we had this resource in place. We had this Oasis in place that the community could look to for a source of refuge. Just to give you some context, in the first half of the year when we were doing the spring semester, we would average about 4 patients per hour. That's ED speak, that's how we think. 4 patients per hour. When Delta surge hit, that number went up to as high as 30 patients per hour. And not only did we see it in the data, but we felt it. You know, in the very beginning, it would be a trickling in of patients when the tents first opened up. But if you were to go to the site when Delta first hit, this is what you would see. And this is a snapshot about 10 minutes before the testing site opens up. And here you can see we've got 3 lanes of cars, 10 cars deep, lined up for testing. What you can't see on this bottom picture is not only the lining up here, but the line actually extends into the street, that major thoroughfare of Hamilton E. Holmes Boulevard. So the testing tent would open often with 30 to 50 cars waiting to get tested. And so we knew at this point we had truly activated our Oasis mode, and we were so thankful that we kept this infrastructure in place, that we were able to meet this need when it arose. And so it wasn't just felt that we had the information, the data to support these feelings as well. Through the course of that first semester, we were able to enroll 301 unique study participants. And like I said earlier, averaged about 19% of total RADx enrollment during that spring semester. In addition to this, of the 11 devices that were tested and validated through the Atlanta-based RADx program, at our APS site, we were able to enroll 5 devices or bring 5 testing kits in line as part of that total. And these devices were varied from different technologies that are very common, such as the anterior ear swabs that we're all used to more novel devices like saliva and gas detection devices or breathalyzer devices. And what's really cool about this is that these are actually devices that students might one day use personally. And now, because of this project, they can say that they contribute to the device development. Notable achievements in the short term were that in that spring semester, like I said, we set a goal of 5,000 and we were able to reach 96% of that goal. Again, done at a time when the desire for testing had gone down precipitously, but we were still able to bring this to a lot of families. Also, in real time, overall, we've been able to test over 15,000 people as of December 1st. And of course, this is driven mostly by Delta, which we didn't predict or even think of when we put this in motion. And so it went from a nice to have resource to an essential part of this community's mitigation of that third wave. Initially, we had targeted this for children, and because of Delta, because of how this thing spread, we actually ended up impacting our adults even more so. With over 4,000 kids tested, though, that's nothing to shy away from. I still think that's a pretty impactful number. And then we've also tested over 11,000 adults. So one of the lessons I, for one, will always incorporate is to encourage my research and my partners to consider bringing these to other communities just because of the impact that we can have. As we think about our future work, I think one of the things that really stuck out for me on this is that we need to think beyond that fourth wall. When I talk to my friends in show business, they always talk about this space that separates the performer from the audience. And in science and healthcare, we also have this impenetrable barrier that actually doesn't really exist, this fourth wall. And I think we should strongly consider breaching this wall as we look to future projects, because we can then optimize our pooling for clinical research. Because outside of those walls is a very willing and rich environment of participants who would add to the medical knowledge. To do so requires leadership team that's very proactive and very intentional, as we had on this team. And as a medical school colleague always reminded me, being intentional, being inquisitive is what we do as scientists. And so when we activate these resources, we can actually take our projects into Oasis mode as well. So I end this talk with my first slide, to consider hybridizing all of our projects. It's a great strategy, because when you find dual purpose for your project, you not only get to your initial goal, but you can leave an imprint well beyond what you ever thought you could. In this case, by hybridizing our project, we allowed our research team to engage in a virtually untapped market of the Atlanta metro area. It also provided a consistent testing resource for a community that really struggled to get access. And then when you feel like you've done enough, you feel like you've asked all your questions, ask some more. Keep asking questions, especially of the people that you serve. Had we been fixated on the plan and the process that we thought we had put in place or would put in place, we would have limited our impact. The idea of moving around to different schools or relying on school nurses who might not be willing to do the testing at the scale that they needed to would have probably led to an outcome that wouldn't be as desirable as what we got here. But by asking simple questions, what do you need? It led us to the right testing model, and truly everybody benefited from that. And lastly, rely on your team. The team acronym in some circles stands for Together Everyone Achieves More, and that certainly was the case here. When we built that team with our community partners by leveraging their credibility in the community for APS, knowing them to be a trusted messenger, it bridged that gap with the community. Leveraging on our community partner to handle the ebbs and flows of volumes allowed us to keep the site up and running. That's what ultimately gave us the success that we've had so far. And this success is definitely a team effort. And I know you get in trouble when you start highlighting individuals, you might leave somebody off, but I have to take this time to thank the entire team for all the effort, starting with our principal investigators, Drs. Voss, Lamb, and Martin, who had the foresight to say we can do something more than traditional clinical research. We can have an impact in our area, and just giving the green light on everything, almost everything. So I really appreciate their foresight. I really appreciate their support in everything that we did. To our on-site team, who battled all manners of weather and just were rock stars when it came to enrolling patients. This definitely could not have been done without you. And to all the advisors, mentors, and supporters along the way who contributed their expertise, contributed their talents, really, really helped us take this ball over the goal line. And so a special shout out to them as well. Of course, I cannot go without thanking my family as well, who endured numerous RADx meetings, and at the same time, we're always the biggest fans of RADx. Thank you to them. And with that, the talk is over. With that, I encourage everyone to go out there and make your area an oasis wherever you can. And I'd like to see if anyone has any questions.
Mark, that was just terrific. Absolutely terrific, and an amazing journey for you, and a reflection of how it takes a village to do research. And it also takes a lot of creativity and thinking outside the box.
Right.
So my hat's off to you and this concept of what do you need? I love it. So I'm sure there are lots of questions. Please put your questions in the chat because I don't see a Q&A here, but I might be missing it. So
Are we allowed to unmute and ask questions, Claudia?
you know what? I think that's fine because I don't see anything popping up. So why don't we do that? It's more interactive that way.
Oh, I see somebody asked the question here. What's the future of the APS site? So we are still enrolling. We went down to the nadir again as Delta kind of was resolving. And then now with Omicron, we're seeing an uptick again. I got a text that there was a kid that tested positive in one of the classrooms. And so the whole class was sent to the APS testing site to get tested. So it's still functioning as a resource, not only for the students, but then also for the community. The plan is to keep it open until June of 2022.
Now, Susan Brasher asked, do you need help?
Always, always.
Absolutely. If you have any ideas, reach out to Mark directly. That's
Absolutely.
terrific.
Absolutely.
So Mark, what would you say is the most important take-home message point that you learned from all of this?
Ask questions. It's especially if you have expertise in an area, people will look to you to give the answers. My expertise, of course, is in ED, and so worked on a few projects there, collaborating with different service lines. And so people, and I feel initially asked me, what can we do? And it was nice to give them answers. But I'll tell you, when Dr. Johnson asked, what do you need? That was the key statement of this whole project. Just continually asking questions, is this the right thing? Should we modify it? Never being satisfied with the model you have in place and always trying to look to refine it, I think is what keeps it going and keeps it adaptable, because the situation has certainly changed from where we were in November to where we are now.
Okay, and Stacy says, I know she can speak for herself, love the concept of removing the fourth wall. Yes. Related to that, do you see any evidence of inspiring the next generation of researchers and inspiring students to study medicine through their experience with this? Great question.
Yeah, so Dr. Johnson, who, for those that don't know, is a general pediatrician here at Children's Healthcare of Atlanta. I call her the school-based healthcare queen because she set up about 26 school-based clinics in the Georgia different school districts. And so she actually also jumped on this and started a rotation where pediatric residents at Children's Healthcare of Atlanta, Emory University, would come to the site and experience the testing flow. It was the first time we'd ever done it, of course, so we're still, curating that experience. But I think opportunities like this are important to start to expose our undergraduate medical students and graduate medical students through these in-person experiences.
Absolutely. So with all this newfound knowledge, Mark, what's your next step?
Yeah. So one thing that, is a challenge for us as we are in the ED taking care of, kids with acute COVID-like symptoms or MISC, anytime we offer folks, the opportunity to get vaccinated, we've set up an alliance with a community partner to offer vaccinations right outside of our EDs. There's still a great deal of hesitancy. And so one thing that I've been drawn to is figuring out what's that hesitancy. And I think my next work is overcoming, um, I guess, information in this digital age where your one's source of information is arguably questionable. And so what can we do as healthcare experts to bridge that gap and build that trust as it relates to vaccinations is probably my next area of focus.
Fantastic. Anyone else from the crowd? So Mark, do you see further expansion of the school-based testing sites now with the next round of the variant, and what's the long-term plan?
Yeah. So I think, factoring in things like supply chain and personnel resources as we struggle at the hospital to keep our staffing above a critical threshold. I think one of the things we're looking for in this project as an extension is what do we do? How do we mobilize resources to meet an acute demand? As you saw in one of the slides, demand went down to a very low amount in June and July. But then again, now in the winter, and this is our second winter with this, we're seeing that surge. How do we mobilize our resources so that we essentially have a strike force that can go and meet that demand? So I think that's the next phase for this group, is to keep the cohesiveness together when the tide is ebbed, but then how do we release them to the community when the tide is flowing? That's going to be one of our next challenges.
Great.
Somebody asked what was the turnaround for the PCR test results. So as long as 48 hours for the PCR test at the height of Delta. It was about 48 hours. And then when things were, tumbleweed flowing through the testing site, you could get the result that night if you came early enough in the day.
Now, do you think they'll start to utilize some of these rapid tests where the results are available within 20 minutes?
I do, especially as we get more information about how specific it is and how sensitive it is. I think that will ultimately give us the confidence that it's a good, at least screener for disease. And then probably using PCR as a backup, do this DNA sequencing if variants become an issue and things like that. So I think there's an opportunity there, yeah, for sure.
So we have a couple of more questions now. How many RADx experimental devices did you use?
We did about 5 through the APS testing site. Ultimately, it was 11 from about March till now total for the Atlanta-based RADx group. And 5 of them, or the APS contributed to 5 of those devices.
And were these results shared with the APS school nurse or school records?
So yeah, APS actually went ahead and expanded upon our program. So once we locked down this testing site, they actually then contracted with our community partner to do surveillance testing with them. And so they got consent from all the families to do not only the surveillance testing, but then to also be willing to share the results from the PCR testing with the APS leadership only, so that they could then, inform families if needed, get people tested if needed, and mitigate the spread there. We also shared certain milestones. So when we got to 1,000 folks tested, APS actually did a short video promo, including some of our research team on there, and promoted that on their different social media websites to kind of foster continued involvement from the folks in their APS community.
And now, Mark, I know that you guys used the Ronald McDonald mobile van, so that was really an innovative repurposing of resources that were available. Can you just tell the group a little bit more about that?
Yeah, so asthma care is, or asthma as a disease is quite impactful here in Atlanta for many reasons. We were seeing lots of kids over the years coming with pretty significant asthma exacerbations. And so our Hugh Spalding based crew applied for and received a grant from the Ronald McDonald Care Mobile Foundation to set up this Care Mobile that would go from school to school, initially in 13 schools, to offer asthma clinic services. So refilling of prescriptions, PFTs, that kind of thing. And when the pandemic hit and shut down schools, the asthma van was, of course, put on the in the parking lot. And so it was essentially sitting there as an unused resource. And so one idea that we had was to utilize that resource, like you said, repurpose it for the immediate need, and then go from there. And so we used it one time at our Mexican consulate, and it was nice. We were able to run devices in real time there, multiple devices in real time. It's a dream. It is truly a mobile clinic. You've got Wi-Fi access, you've got computers on board. It is quite a nice resource that we were able to use. But ultimately, I think our testing tent worked better for us.
Excellent.
Well, thank you so much. I don't see any other questions in the queue. So with that, I just want to thank you so much for this talk today, Dr. Griffiths. It was inspiring, and the level of detail that you provided was just really fascinating, but yet also so practical, and sort of giving us a roadmap for building such a wonderful infrastructure for bringing those two worlds together, as you said. I think it really serves as a model for a lot of other people to follow. And I think that this was such a spectacular way to close out this 2021 COVID Force seminar series. I will let everyone know that if you have some COVID related research that you'd like to showcase in this format, we'd love to hear from you. We'd love to give people an outlet in order to share this great work with others and potentially facilitate collaborations. It sounds like Dr. Brasher will be reaching out to you to potentially get on board with the team.
Awesome.
Thanks everyone for joining today, and we wish you a joyous and restful winter break, and we'll see you back here in 2022.
Great. Have a great one, everyone.
Thank
Thank
you.
you.